My project examined how caregiving style and adverse childhood experiences are related to disordered eating in college students. Disordered eating behaviors, or DEBs, are eating patterns that typically include food restriction, binging, purging, or other methods to lose or control weight. One also might attempt to conceal these behaviors or to avoid conversations and events associated with food. While these behaviors aren't as severe as an eating disorder, they can cause impairment at a similar level. DEBs pose serious health risks and elevate the risk for other mental health issues as well. DEBs are important to study because college students are particularly at risk for DEBs, and pre-existing DEBs may worsen during college years. This is likely due to the stress that coincides with the transition to university and a novel lack of caregiver support or scheduled eating times and more independence in selecting meals. So what are adverse childhood experiences and why are they so important to study in our population? Adverse childhood experiences, or ACEs, include childhood abuse or household dysfunction that occurs before the age of 18. ACEs have been thoroughly investigated in the college population related to clinically diagnosed eating disorders, but not related to disordered eating. This is concerning considering DEBs are more common than eating disorders and that 60% of college students have experienced at least one ACE. ACEs pose serious developmental and health risks, along with new barriers that could affect overall functioning in university, in addition to the struggle that comes with transitioning previously mentioned. So caregiver psychological control, known as the use of manipulation to control how a child thinks or behaves, has been found to be associated with DEBs in adolescents, although few studies have investigated the relation between DEBs and caregiving style in college students. Research also suggests that resilience-promoting environments fostered by positive caregiving relationships could act as a protective factor against other known risk factors for DEBs. The current study sought to examine the relationship between psychologically controlling caregiving styles, autonomy supportive caregiving styles, and DEBs, as well as the relation between ACEs and DEBs. We hypothesized that greater psychological control and greater ACEs would be associated with greater disordered eating, and that greater autonomy support would be associated with less disordered eating. 612 undergrad students enrolled in Intro Psych were recruited for this study. Participants completed a one-time survey in REDCap that consisted of a demographics questionnaire and 4 measures. These measures assessed our study variables. 476 participants made up our final usable sample. A series of Pearson correlations revealed that greater ACEs, greater primary caregiver control, and greater secondary caregiver control were significantly related to more disordered eating. We also found that primary and secondary caregiver autonomy were significantly related to less disordered eating. Here are tables outlining participant scores on measures used and participant demographics. All study hypotheses were supported. This may be because psychological control prevents a child from learning how to cope independently. This is supported by self-determination theory, considering psychological control may prevent a child from obtaining their psychological needs. Likewise, autonomy support during the childhood and teen years may provide students the ability to learn how to cope with stressors independently, and this is supported by self-determination theory as well, considering that when late adolescent women had their psychological needs met, they were less likely to engage in DEBs and regulate their eating behaviors autonomously. Lastly, the relationship between ACEs, poor mental health, and stress may contribute to the relationship between DEBs and ACEs, considering that DEBs are more likely to occur when high stress is present. Future research should replicate this study with a more racially and ethnically diverse sample. Future research should also investigate gender differences, including differences among non-binary individuals, given that gender minorities are at a high risk for developing DEBs and EDs. Lastly, a longitudinal introspective study assessing both child and caregiver perception of caregiving style should be conducted to reduce bias in reporting caregiving style and to increase the accuracy of child perception. So because findings suggest that controlling caregiving styles and ACEs are associated with DEBs, college counseling centers may screen for ACEs and perception of caregiver style to identify students at risk for DEBs and to better inform treatment. Lastly, because findings suggest that autonomy-supportive caregiving styles are associated with less disordered eating, college counseling centers may implement autonomy support and individual therapy. Thank you.